Welcome to an MUSC Health Podcast. I'm Dr. Linda Austin. I'm interviewing Dr. Perry Halushka, who is professor of pharmacology and medicine at the Medical University of South Carolina and a noted expert in the field of hypertension. Dr. Halushka, I think people have a vague notion that if you have hypertension or high blood pressure, it's important to get it treated. But can you explain exactly why it's so important?
Yes, Linda. What we have learned over the years is that if you successfully lower people's blood pressure, their risk of cardiovascular disease, particularly heart attacks and strokes, decreases significantly. We also know that people that have multiple risk factors benefit even more so by aggressively lowering their blood pressure. We're talking about getting blood pressures down in the 120 to 130 systolic range. As you may recall, for many years we said any blood pressure above 140 over 90 is considered hypertensive, so that physicians in the beginning would try to get the blood pressure just below 140 over 90 and feel that that was a successful treatment. Today we feel that in most cases we should try to lower it even more so.
Now you use a word that people may not be familiar with, systolic.
Yes.
And maybe we should stop and explain what those two numbers are. If one says a normal blood pressure is 120, which is the systolic, what does that 120 really mean?
That's a good question. When the heart contracts and pushes blood out against the blood vessels, that creates the systolic blood pressure or the higher blood pressure. Then when the heart's relaxing and the blood is flowing through the blood vessels, that's what we call the diastolic blood pressure, and that's the lower reading. So systolic and diastolic are the two readings that you'll always see in the physician's office.
So in other words, then the systolic, the high number, is the highest that the pressure ever is within the arteries or the tubes going out of the heart. And the diastolic is the lower number, meaning that's the kind of baseline, that it's always at that level, right?
Yes, that's correct. One of the interesting things, though, as people get older, the systolic blood pressure tends to rise a lot more than the diastolic blood pressure. And so actually we have one particular diagnostic category called systolic hypertension, which again occurs more often in the elderly, and that too we find should be aggressively treated, although sometimes we cannot lower the blood pressure down to the levels we talked about earlier because the patient often cannot tolerate the 120 blood pressures, for example.
The high number, the systolic.
Yes.
Okay, so you're saying that the high number goes even higher as you get older.
Correct.
And that can be hard to treat.
Yes.
So then at what level of elevation does one have to get treated? I mean, 135, for example, 130 over 90, what do you recommend?
Well, there's two ways to look at it. Number one is over 140 over 90 for most people is considered hypertensive and definitely should be treated. If it was 140 over 90 in let's say a 70 or 80-year-old person, we probably would say that's fine. On the other hand, 140 over 90 in a young person, we would aggressively treat because we know that, again, we can reduce cardiovascular risk significantly. If somebody has other cardiovascular risk factors such as diabetes, obesity, smoking, male subject, kidney disease, in that setting, 140 over 90 would not, just below that would not be considered sufficient, and we would try actually to get blood pressures down in the 120 over 70. The nice thing about therapy today is that drugs are extremely effective with very few side effects, and we now have what we call long-term outcome data to show that people truly benefit from the newer classes of antihypertensive drugs.
And yet a lot of people are still reluctant to get their hypertension treated. Why is that?
Well, I think probably the number one reason is that they're scared of the side effects. But what I can assure you is that the side effects are few, minimal, and invariably if somebody does experience a side effect, we have another drug that we can use that would be equally effective. I have been around for a long time, and one of the nicest things about treating high blood pressure now is that the drugs, as I said, are very safe, very effective, and rarely do you see a significant side effect.
Don't you think part of the problem also, though, is that low levels or even moderate levels of hypertension doesn't really cause a symptom, so you don't really feel it?
That is correct. In fact, we in the field call it the symptomless disease because rarely, if ever, does high blood pressure cause a significant symptom. And when it does, it's usually in the accelerated or malignant phase. So, for example, people think that if you don't have a headache, you don't have high blood pressure. Well, that's not true. On the other hand, you could have very high blood pressure and not have a headache, and people would say, well, I obviously don't have high blood pressure because I don't have a headache. Those two things don't go hand in hand unless somebody has really severe elevations of blood pressure, and then they'll have a characteristic headache in the back of their neck.
I'm sure you talk with patients who say, Doc, isn't there something I can do myself, my lifestyle, what I eat to bring down my blood pressure? How do you respond to that?
Well, I respond positively to that. Indeed, any algorithm that you see published today about treating people with high blood pressure starts with lifestyle modifications. Exercise, for one thing, weight loss if somebody is overweight, and also salt restriction. Now, salt restriction is a little bit controversial because not everybody is what we call salt sensitive. How do we know? The only way we know is by restricting somebody's salt intake and seeing if that does indeed lower the blood pressure. But if you lose weight, there are studies to show that your systolic blood pressure in particular can drop 10 to 15 millimeters of mercury without a major weight loss. Sodium restriction in those people that are salt sensitive, again, you can see a 5 to 10 millimeter drop in blood pressure. You start adding those up with lifestyle modification, and you may need fewer medicines in the long run.
What kind of exercise do you recommend?
Well, we recommend aerobic exercise, things like bicycle riding, getting on a treadmill, swimming, running. Those are the kinds of things that, first of all, tend to lower blood pressure. They're healthy. What we don't recommend is weightlifting per se. In fact, there are studies to show that pure weightlifters often have an elevation of blood pressure. So aerobic exercise is what we recommend.
How about walking?
Walking's good too. Brisk walking is even better. I like to tell patients when they say, well, if I walk, I lose weight. You won't necessarily lose weight from walking, but I point out to them if you walk, you can't carry the refrigerator with you. So there's a good chance if you're a snacker and you go out walking when you're used to taking a snack, maybe you can lose weight that way alone.
Dr. Halushka, let's talk about medications in another podcast. Thanks so much.
You're welcome.
If you have any questions about the services or programs offered at the Medical University of South Carolina, or if you'd like to schedule an appointment with one of our physicians, please call MUSC Health Connection at 1-843-792-1414. That's 1-843-792-1414.